patients are often traveling up to 300 miles to come and see us.
Hi everyone, welcome back to Take a Pain Check. Today's episode is a very important conversation about access to care, workforce shortages, advocacy, and what it takes to build a sustainable healthcare model for children living with rheumatic diseases. I'm joined by Brandon Coe, a pediatric rheumatology provider at the University of New Mexico and the sole full-time pediatric rheumatology clinician serving the entire state. Since 2021, Brandon has been providing comprehensive care to children across New Mexico, many of whom live in rural and underserved communities. Brandon, thank you so much for being here.
Good morning, Natasha. Thank you so much for having me on the podcast. I really appreciate the opportunity to talk with you today. My name is Brandon. I'm a pediatric rheumatology nurse practitioner who has been with the University of New Mexico since 2017. And I was trained as a pediatric primary care provider and then made the change to rheumatology about 8.5 years ago now.
Wow, thanks so much for sharing. So what drew you into this field?
Yeah, it's a great question because a lot of people don't know about rheumatology or are intimidated by rheumatology, which is one of the reasons I think conversations like this are so important, especially for the pediatric rheumatology space, because we have a huge workforce kind of shortage issue, which we're going to talk about, I think, later on in the podcast, and really need more enthusiastic, dedicated providers joining the pediatric rheumatology field, including docs, nurse practitioners, and PAs. And so, like getting awareness out about this is a huge issue, a huge thing that I'm passionate about. And, because everybody has their own unique journey to rheumatology, I think. Mine is a very personal connection. My brother actually had a pediatric rheumatologic condition, something called mixed connective tissue disease, which is basically a combination of things like arthritis and things like lupus and things like something called dermatomyositis that are have features of each of those things in a particular patient. And all through my growing up was kind of along his journey with him. He was my little brother, and so I was helping with his medications and his helping kind of with his treatment and going with him to hospital appointments and things like that. So kind of had this sense that I wanted to go into both pediatrics and rheumatology from the get-go. The way into healthcare is different for everybody. I did my undergrad in California and was talking about kind of career options for things. Had a friend who had done a pediatric nurse practitioner program at Yale University. They have a direct entry program, and so kind of put that on my horizons as something that I could look into. So did a bunch of applications and essays and some interviews and things like that, and up getting into that program. There is no rheumatology focus for APPs, advanced practice providers, be it nurse practitioners, PAs, or pharmacists, and especially no pediatric rheumatology focus. So what I did was I went into general pediatrics to start with, the peds primary care program, and did some of my training while I was at Yale. Loved it. Was the first actually pediatric nurse practitioner to do a rotation with that clinic, and initially was planning on going in directly into pediatric rheumatology from there over on the East Coast in Connecticut, but was advised by my mentor to do primary care first and then go and specialize, which I think is not the track for everybody, but was good advice for me, because the rationale was that you can always specialize after doing primary care. It's very hard to go back to primary care after specializing because you can take kind of all that general knowledge and then focus it down, but it's hard to go from a focus and then kind of expand back into being a generalist. So I ended up doing pediatric primary care at a community health center in Connecticut for about 3 years before transferring to the Indian Health Services and moving out to South Dakota on the Lakota Reservation and doing primary care there, and then moving from the Lakota Reservation down to the Navajo Reservation in Chinle, Arizona, to do pediatric primary care there. And it was a great experience, all three of those places, helping to broaden and deepen my knowledge of pediatrics in general, made great connections with families all throughout, and then also got to manage not just rheumatologic conditions kind of intermittently, because as primary care, you see everything, but also a lot of related conditions and other kind of subspecialty conditions as a generalist, as their primary care provider. So helping to get a sense of what the breadth of all of those things look like and how they integrate into a particular child or family unit. So that was great. I loved primary care. I was actually planning on just doing primary care after that because my had gone kind of so far afield from that initial specialty tract and was really having a very fulfilling career in primary care. But as it happened, when I was in Arizona on the Navajo Reservation, our closest specialty referral center is actually across the border in Albuquerque, New Mexico, and is the University of New Mexico. And they had an opportunity they were restarting their pediatric rheumatology clinic. They had not had a pediatric rheumatology provider for years. They had a new attending that was coming out, Dr. Kellen Pocus, who, as part of his contract, wanted to hire a nurse practitioner to join him there to help rebuild the clinic. And so that position got posted. I learned about it and made the move from primary care back to pediatric rheumatology, as it seems fate would have it sometimes. And so from there, I kind of got set up with as a new pediatric rheumatology nurse practitioner at this kind of fledgling clinic and have been trying to help grow things ever since.
Thank you for sharing that. You definitely had a long journey, but also like lots of different experiences in different places as well. Why did you
Mhm.
decide to settle in New Mexico, and what is so unique about the care over there?
So New Mexico has a huge need for kind of healthcare in general. There's access issue throughout from top to bottom, primary care all the way through subspecialty for both adults and pediatrics. But pediatric rheumatology in particular, there is some of your listeners may be aware, like there's not a lot of pediatric rheumatology care evenly distributed throughout both the world, throughout the United States, and places like New Mexico that tend to be more rural and have less population density and don't have some of the large academic research centers like they do on the East Coast, the West Coast, and kind of the middle of the country, tend to not have as consistent subspecialty care, unfortunately. Um, so pediatric rheumatology in particular has, like I said, not been kind of consistent attending or pediatric rheumatology providers there throughout. So lots of these patients have had to travel out of state up to Colorado, across to down to Phoenix in Arizona, and then across the border to Texas. And so rebuilding a pediatric rheumatology clinic there and being able to provide care locally to patients locally has been a huge addition to the university there. Some of the unique challenges for things is that New Mexico has a very low population density, and so we have Albuquerque as an urban center where the university and most of the medical care is located, but we can serve the entire state, and so patients are often traveling up to 300 miles to come and see us. I feel like I actually didn't choose New Mexico. New Mexico kind of chose me. I didn't know really anything about the state and or kind of the population before moving down to the Southwest, working on the Navajo Reservation. I am a city coastal boy by by upbringing, and so kind of these wide open spaces and big geography and different cultures were really a new immersion experience for me. But working in the Southwest on the Navajo Reservation gave me an appreciation for the cultural diversity and the geographic scale over which healthcare can kind of play out, where you are thinking about kind of how weather affects transportation to the hospital, how kind of rural exposures affect kind of your risk stratification for things like infections, how things like access to refrigerated medications are important for patients who are on specialty biologics and things like that for their rheumatic conditions. And so, it has been a wonderful but sometimes steep learning curve moving over to New Mexico and to the Southwest.
What does a typical day look like for you when you're serving this like entire state, and how do you manage kind of the different patients that come to you?
Every day is different. It's never dull. Pediatric rheumatology always keeps you on your toes because rheumatology is, a variety of different conditions, inflammatory conditions, and people think of arthritis as kind of the classic rheumatologic condition, which is true, is our kind of bread and butter, I suppose. But there are also lots of rarer things and other things, multi-system conditions that can go along with arthritis or affect kids, like lupus and vasculitis and autoinflammatory conditions. And New Mexico, interestingly, has more than its fair share of those things for reasons that we don't fully understand. Um, we see a lot more kind of unusual presentations, unusual conditions, and kind of overlapping conditions than one would expect in a clinic like ours. Um, and there's some ongoing research going into whether there's some kind of unusual environmental exposure or anything like that that is contributing to that. But a typical day, we have clinics set up, and so I'm seeing patients regularly through the clinic, but also fielding on-call calls and consultations from community providers, from other hospitals and surrounding areas, and then managing our inpatient service. And so if there's kids in the hospital, we're finding time to go over and see them, kids that are infusion unit, things like that. I am fortunate that unlike kind of back in 2021, when we lost our pediatric attending who had trained me, for a while there, I was basically the only full-time provider in New Mexico. We had some traveling docs that were helping with things coming out once a month to provide some coverage, which is wonderful. And I have some great colleagues in my nephrology department that help cross-cover things as they can. Um, but yeah, it was really busy there for a while. And as a nurse practitioner, it's kind of a unique role to be in where we are not normally the ones who are spearheading the entire clinic in that way. And so I think the very unique opportunity that was provided to me, and that I'm thankful for the faith that the institution placed in me and the training that I had from my mentor, was to allow me to really expand my scope and take on the role of being kind of the lead provider for this clinic for the time temporarily, to be able to help keep the clinic running while we rebuilt and kind of created connections that allowed us to keep our patients in New Mexico, being able to get care in New Mexico and still provide high quality, state-of-the-art pediatric rheumatology care to patients that so desperately need it. We had to be pretty creative with that. And so in addition to having locums or traveling docs that come out to help out with things, we created a partnership with the Children's Hospital of Colorado's Pediatric Rheumatology Department. Big shout out to them and Dr. Brian Shirley. They've been wonderful supports throughout this entire, I guess it's been almost 5 years now that we've been doing this, where I will meet with them on a kind of a weekly basis to review cases and to get kind of consultation support to help talk through difficult clinical scenarios and things like that, and make sure that we are kind of collaboratively on the right track for things for patients. And in addition to that, because we had such limited capacity, one provider can't provide all of the care that patients need for a big state like New Mexico, especially with new consultations, because not all of our consultations are for true inflammatory conditions. We get a lot of consultations for things like amplified musculoskeletal pain, lab results that people aren't sure how to interpret, and things like that. And so we've had to be very targeted in how we where we had patients coming to be seen, whether they were going to be seen at the University of New Mexico in my clinic for like more emergent or kind of severe conditions to be evaluated, or whether these were patients that we had the flexibility to be able to have them be seen up in Colorado by my colleagues there, who provided basically overflow referral support for things. So a certain amount of patients would be seen up in Colorado, a certain amount of patients would be seen down in New Mexico, and then those patients that were seen up in Colorado that ended up having a rheumatologic diagnosis, we could then bring home back down into New Mexico for ongoing care. Since this year, we have hired a new pediatric rheumatology attending who is part-time, Dr. Katie Schultz. So I have more help than I've ever had, which is fantastic. So we are kind of rebuilding the clinic, and it's 2026 is off to a good start with looking up for New Mexico and us being able to expand our patient load and the care that we're able to provide now with two providers is great.
Thanks for sharing that, and I'm glad that it's slowly expanding, even if it's, one more person. It definitely will make such a big difference to lots of patients. So, do you find that, patients are coming to the hospital and like they're saying that they have these aches and pains, that they're going to like their family provider, their primary care physician, and they're saying they have this these aches and pains, like, are they not getting referred to because you don't have the capacity to like take on more? What is the kind of gap? Like, do these patients not get seen at all by rheumatologists if they potentially have this pain because there's not enough care providers over there? What is the actual like logistical aspect of what these patients go through?
Yeah, that's a great question. And I think there's a lot of layers to that, unfortunately, so in a place like New Mexico, I think one of the first issues with delays in care is lack of access to primary care, actually. And so I was talking at the beginning about how great of specialty primary care is. I loved that as well. We definitely have uh, a access issue there. So patients may not even have somebody that they can go to regularly who knows them to get these initial complaints evaluated in the first place. Um, Once patients do access primary care or are able to get into primary care, then there's a knowledge issue where kind of having primary care providers familiar enough with our condition so that these things do happen in kids, so things like arthritis, things like lupus, so that they have the knowledge base to be thinking, oh, okay, wait a minute, this is out of the realm of what I would normally expect for, say, a sports injury or a strain or a sprain or something like that. What is the next step? What do I need to be thinking of in terms of my evaluation? And so trying to help fill in that knowledge gap by talking with our primary care colleagues. I do a lot of lecturing and teaching, both with our residence program and our nurse practitioner and PA programs. But also there's a rheumatology echo program that basically provides teleconsultation services for primary care providers throughout the state. All of these things are really important parts of making sure that once patients get into primary care, then the primary care provider is able to recognize that that is a condition that could be a rheumatologic condition, then the next step to reach out to us for a referral. Once the condition's been recognized as potentially problematic, then I think the next barrier is that kind of referral backlog and that kind of pediatric rheumatology access issue where, okay, primary care provider sees a patient, it says, okay, I'm worried about arthritis or lupus or something like that. Now, how do I get them in to see pediatric rheumatology? They would then make a call, typically to me or to whoever's on call, but normally it's me. And then we'd have a discussion about what needs to happen if this patient meets criteria to come in for an evaluation at the University of Mexico, if further lab work or further imaging or further follow-up needs to happen, or if this is a patient that needs to be seen up in Colorado Children's Hospital, or can be followed by primary care for a little while to see kind of what direction things go in. Um, and so, ideally, like this is kind of an unusual setup. It is the reason we have to triage all of these calls is because we have limited capacity. We are not able to see every referral that comes in right away. And to prevent there being us running out of space for the patients that need to be seen right away, we have to be careful about how many patients we accept, if that makes sense. We are managing about 350 to 400 kids throughout the state with one full-time nurse practitioner, one part-time attending, and one once-a-week traveling doc for things. And so, as you can imagine, it gets pretty tight as far as making sure we have follow-up appointments and then urgent slots for our patients who are already established, let alone getting in those new patients from the hospital or from referrals. And so to make sure we have that space, we have to be careful about we unfortunately can't accept every referral. So we have to send some people out of state or help our primary care colleagues manage those things. That would not be as big of an issue if we had more pediatric rheumatology providers.
If they obviously have more people that are in training, like, is there some sort of like
Mhm.
announcement or something where they can be like, okay, can people start working in New Mexico instead, or can they start this like different type of, I guess there's lots of different ideas that, anyone could have on how to maybe get some more.
That is, I think, the big push that's happening right now is to both increase training and an interest in pediatric rheumatology for MDs and DOs to get to become kind of pediatric rheumatologists to go through the formal fellowship training program. And I knew a new fellowship program just opened up in Phoenix. There's lots of fellowship programs throughout the country. One of the dreams would be to have a fellowship program actually in New Mexico at UNM that we could train our own kind of providers and basically grow our own pediatric rheumatologists. That would be fantastic eventually. Um, but one of the other things we're doing is also trying to really build up awareness within the advanced practice provider APP community, and can provide training and support for them to have the knowledge and the experience to be able to get into rheumatology in general and pediatric rheumatology in particular. So organizations like the Rheumatology APP organization, or RAP, which I'm involved with as a pediatric, and their pediatric chair, helping really kind of push that educational component. And then organizations like the American College of Rheumatology are all trying to kind of bring more nurse practitioners, PAs, um, and PharmDs into kind of the pediatric rheumatology and rheumatology workspace in general, because all that helps with access. If I had a clinic that had 5 providers instead of 1.75 providers, we wouldn't be in this kind of backlog that we're in, or this kind of this tough spot where we have to triage every single patient before they're able to get into clinic. We'd be able to see pretty much everybody and make sure that we got people in a timely fashion while not compromising care for the patients who are already in the clinic. And so that is the dream, is to really build up the fellowship programs, bring more advanced practice providers into the rheumatology kind of field, and then kind of increase education with our primary care colleagues so that they are comfortable with and well equipped to recognize these conditions and help get these kids into to specialty care ASAP.
So for patients that are asked to go to Colorado, I'm assuming not everyone can afford something like that.
Yeah, it's a huge burden, both for time, travel, financial, time off of work, things like that. Like it is really tough. And so it's definitely not an ideal position to have to put our patients in. The insurance companies in New Mexico are aware of kind of our shortage issue, and so they are willing to provide coverage for out-of-state travel for rheumatology evaluations. And so if we recommend that a patient can't be seen here in New Mexico but needs to be seen up in Colorado, they will normally help cover travel rate costs and things like that, and then cover the visit at an out-of-state specialty center, either in Texas or typically Colorado. Um, but still, it's a terrible position to have to put patients in, to have to go travel. Not only, we have patients who have to travel for basically half a day or more just to get to meet Albuquerque, but then to make that trip, from the bottom of New Mexico, the southern tip of New Mexico, all the way up to Denver, that is there's a huge commitment and a huge expenditure of time, resources, energy, things like that, that hopefully will not be the case long term for these patients.
And being the only provider, I mean, now you have someone helping you out as well, like you attending. But I mean, how do you take care of yourself? I feel like is there any burnout in this job because you're the one doing kind of everything?
Yeah, I mean, it is. It's a balancing act, right? I think the thing that helps a lot is that the work and the care that we provide is so gratifying, right? Pediatric rheumatology is a wonderful field to be in. Here's my plug for everybody, is that I can work my butt off all day, pretty much every day, and still feel really good about what I'm doing and feel rejuvenated by the fact that, if we can get in, if we can get these kids in for care early, and figure out kind of what complex immunological dysfunction is happening, we have a ton of very of tools to be able to help fix that. And the toolbox just keeps expanding. We're having new medications available every day. There's fantastic research going on, and they're kids, so they're really resilient. It can be heartbreaking sometimes to see these kids suffering with these really severe, potentially life-threatening conditions, but if you're able to get in and kind of get treatment started, the turnaround can be amazing, and the quality of life change from going from feeling awful and not being able to do any of the things that make up a normal childhood to suddenly being able to go back to doing everything that they wanted to do, and kind of school, sports, you know, whatever they basically had been enjoying in the past. Um, it is really great, and kind of being able to get to know families, get to know kids, watch them grow up, um, is and help them through all these really hard times, is really what makes the work worthwhile. And so, yeah, try and make sure I get enough sleep, trying to exercise, trying to get some leisure reading in and things like that. But I've got now 3 kids, and so they keep me busy as well on the home front for things. And um, there's you definitely have to make sure there's a balance there. And I have to give credit to my institution, which has really helped kind of make sure that I have the support that I needed, both from a time standpoint and my team, which the nurses that I work with, and my kind of the rest of my colleagues who, my traveling docs, my colleagues up in Colorado, my new pediatric rheumatology colleague, everybody's been super supportive to help make sure that none of us are getting burned out. We're all really helping each other kind of figure out the best way to creatively use the resources that we have to provide the best care to the patients that need them here in New Mexico. So long answer to being basically like, yeah, it's tough, but it's worth it. It's super rewarding, and there's tons of really interesting ways um, to do pediatric rheumatology and really tailor care to every patient. And like I said, and always tell everybody when they ask how things are going, it's never dull. You don't want to be bored, and you'll never be bored in pediatric rheumatology.
And you're also heavily engaged with other initiatives, like on committees and things like that, to be more knowledgeable and be more engaged with rheumatology. So, can you talk a little bit about the initiatives you're doing outside of work?
Yeah, and that all goes, I guess, into the advocacy part of it, which is another really rewarding um, part of my day is being involved with, like I mentioned, the RAP or the Rheumatology Advanced Practice Provider Organization, where I'm the pediatric chair, and really have been engaged in trying to build up curriculum and education and outreach for advanced practice providers to get into pediatric rheumatology, and for our existing pediatric rheumatology APP community to really support and build that network and grow that community. So that's been fantastic. We have conferences, we have great educational resources, we have more things up that are coming out, as far as resources for our colleagues every day. So love that. And is definitely a creative outlet, like lecturing and things like that with uh, um, different programs. I lecture back at Yale for my old pediatric rheumatology or pediatric nurse practitioner program. I lecture at UNM for the residents and the nurse practitioners and the physician's assistants. And that I used to write a lot and draw a lot and things like that. I don't have time to do as much creative writing or art per se, but I like to think that my outlet for that creativity goes into kind of teaching, and that becomes its own kind of creative act things. And so, in addition to that, and doing that kind of outreach and advocacy, there's also the New Mexico Arthritis Foundation, which is kind of we is trying to increase its presence in New Mexico, and we're really working with our board members to rebuild its presence in New Mexico. But we have our arthritis walk. We've been able to do a bunch of initiatives for juvenile arthritis families in terms of camp, not a camp. We're hoping to have a camp, a family day camp kind of a thing, and then some pool days and barbecues and some other kind of educational activities, partnering with the YMCA here and the Arthritis Foundation. So I'm the medical chair for the New Mexico Arthritis Foundation as well. So working with our colleagues and community to build up awareness for rheumatology in New Mexico. Um, and some of the families here also helped found a National Scleroderma Foundation chapter in New Mexico too. And so I've participated in those walks and helped with some of that education as well for the Scleroderma Foundation. So it seems like, I think there are big challenges with awareness for these rare conditions and people feeling isolated and not having a community. But that challenge also presents a lot of opportunity for advocacy, for bringing people together, and for kind of partnering with both families who are engaged, but also other providers and other organizations to help bring those resources and bring that community to New Mexico. And so that's been fantastic. Oh yeah, shout out. We have a uveitis organization as well that's kind of homegrown that is unique to New Mexico and founded by some of the families here.
That's amazing. Thanks for sharing that. So, just looking ahead, what would success look like for pediatric rheumatology access in New Mexico 5 to 10 years from now?
Yeah, so that's a great question. This is kind of the dream, right? And it's kind of the vision board. What have we been working for this whole time? And kind of since coming out to New Mexico trying to help kind of rebuild the clinic, having some bumps in the road, and now kind of weathering COVID, which was its own challenge and things, and then kind of now coming out on the other end with a new, freshly recruited pediatric rheumatology attending, kind of building up a nursing workforce, having this partnership with Colorado Children's. What is the next step from here? So, what I'm hoping for, and this I think is a nice model for pediatric rheumatology access in lots of areas that have kind of this rural challenges where there's not a lot of providers and it's difficult to attract providers because we are not a large coastal academic center and like that. What the hope is to continue to grow, and so we're actively recruiting for another pediatric rheumatology attending, so to have three full-time providers. And then to eventually build a fellowship program so we could train our own pediatric rheumatologists here in New Mexico that would be kind of hopefully sticking around in New Mexico and continue to provide care here. Um, and then also attracting more subspecialists in general, pediatric rheumatologists and other pediatric subspecialists. One of the things that I think would be really helpful for that would be, we are advocating for trying to create loan forgiveness and loan repayment on the state level for subspecialists who are willing to come and work in New Mexico. And so trying to incentivize people to come here. It's a wonderful state, but a lot of people don't know about it. Like I said, was not familiar with New Mexico before moving out here. But it is known as the land of entrapment, as well as the land of enchantment. And the reason for that is once people get here, they love it. There is amazing landscapes, tons of world-class skiing, hiking, rock climbing, tons of outdoor stuff to do, rich cultural layers with kind of this. It is actually the longest continuously settled place in the United States, which is a fun fact for New Mexico. And so the layers of history and culture that have built up as different peoples have kind of come through the area are just really like amazing to be immersed in. Um, and so getting loan repayment and forgiveness for subspecialists in the state, I think would help with that access issue. Building up the pediatric rheumatology fellowship program will help with that access issue. And then continuing to partner and build our regional kind of network or regional model for pediatric rheumatology care. Kind of this hub and spoke idea where we are in Albuquerque and then connecting with the big specialty center up in Colorado Children's. We have colleagues that are kind of spread out throughout other parts of the Southwest that are also kind of in similar positions, trying to provide care, but without the big kind of academic support. And so to enable more pediatric rheumatologists to go out into solo or small practice settings to provide care in smaller areas, we could create that big network where we could all be talking once a week, kind of, and have this consultation service where it is a kind of we call it a Southwest Access Group model. And I think that could really help improve access to care for pediatric rheumatology throughout both the Southwest, and you could expand this or replicate this in lots of other areas, both in the United States that have these issues and around the world. It's 2026. We have tons of connectivity and networking options that we never had in the past. And so if there's any silver lining from COVID, it's knowing that telemedicine is really a very flexible and powerful force for providing expanded care and support for all kinds of things, but especially pediatric rheumatology.
I mean, I'm from Canada, and I find that it seems like in the States it's very different in the way that nurse practitioners are playing a even more significant role in the patient's healthcare. Can you talk a little bit about kind of like the roles between a rheumatologist and a nurse practitioner? In your case, like there is no rheumatologist. Is that quite prevalent in the States?
So it's not. I'd love to talk more about this because this is something that I think is a evolving area. And one of the things that RAP is really trying to help create some structure for. I think that's the tough thing. As I mentioned in the beginning, there is no formal training program for rheumatology advanced practice providers, be it nurse practitioners or physician's assistants, where in the States here, nurse practitioners, there's the RN level and then kind of a master's or doctorate trained clinician as the nurse practitioner. And so we are independent providers and so can see patients independently, prescribe, have full kind of prescriptive authority and things like that, and depending on what state you're practicing, because there's a lot of variability there too, legislatively, like scope of practice. Um, but for a very specialized position like pediatric rheumatology, a lot of it becomes like, how does one get trained in the specialty itself to kind of build on the that provider role. And so, and there is no standard formula for that yet. One of the things that we would hope for is to try and build that. And there's actually a curriculum that's available. There is a fellowship that's available for rheumatology, for adult rheumatology, kind of like a APP fellowship through the American College of Rheumatology, which is a great resource. And there's also something called the Step into Rheumatology curriculum through the RAP organization, which has pediatric and adult kind of elements in it specifically for advanced practice providers. But it's tough. Right now, I would estimate, about 40 of us, pediatric rheumatology advanced practice providers, and all of us have had to kind of carve out our own space in this field. And so everybody does it a little bit differently. Everybody is kind of plays a different role in their organization, be it kind of specializing in a certain condition, providing kind of direct patient care, providing kind of inpatient care, providing like some people are specializing in ultrasound, some people are specializing, the PharmDs are helping with medication and management and guidance. Um, there's a lot of different ways to do it, which is, I think, again, both a challenge and an opportunity, because we are kind of finding out what works best at every particular institution. Uh, and which is challenging because nobody's quite sure like where the scope goes, where the scope ends, what's the best way to integrate a nurse practitioner into practice or a physician's into practice is. But also is an opportunity in that we can really be creative and work with our institutions, work with our MD and DO colleagues and say like, hey, like what kind of training can be provided that we can best like really fill these roles. For instance, I feel like I am a great example of what the potential could be for that, in that out of necessity, because we didn't have pediatric rheumatology attending, my institution was willing to kind of help support my role with this collaboration with Colorado Children's Hospital and our traveling doctors as support to really allow me to take over the clinic in a way that I think is not the typical case for most nurse practitioners or APPs. I was really fortunate in that my entire first 2 years of training in pediatric rheumatology was set up like a fellowship. And so my Dr. Callan Pocus, who was my mentor, was basically like, I will teach you everything I know. And we spent 2 years joined at the hip for all intents and purposes and seeing everything. And so by the time he left the clinic, I felt relatively, I felt able to try and take on that challenge out of necessity. It was kind of scary. I will not lie. It was a steep learning curve, pretty intimidating, but he had trained me well, and I feel like I had a good foundation in just in pediatric care in general because of my years doing primary care, which was really helpful. I was not a brand new graduate by any means, and so I was able to leverage those two things in with the support of my institution and the support of my colleagues in Colorado and my locums colleagues to really be able to become an attending and take on inpatient care, take on full outpatient care, take on all of our consults and things like that, and had the support to be able to manage most things. And then when there were things that were difficult, I had resources and things that and colleagues who I could say, hey, this is beyond my training, beyond my level of expertise. I need your input here. And there were people ready and available to be able to weigh in and say, here's what I would suggest. Here's what I think we should do for the next steps. And so again, it's a perfect example of how a place that has few resources and does not have the kind of traditional model of a pediatric rheumatologist or pediatric rheumatologist center can take and train a APP or a new provider to come in and provide the care necessary locally with support from, say, like telemedicine support or teleconsultation support from a larger specialty center and kind of creative use of say like locums providers or part-time providers to help support that. So where there's a will, there's a way.
What is one piece of advice that you would give for trainees who are thinking about entering rheumatology?
Lean into it. It is a fascinating field. You really like get to keep your detective hat on all the time. And I think there are few specialties that offer the same level of opportunity for professional growth, for kind of expanding your scope of practice, for being able to really stay on the cutting edge of research with some of the most fascinating and complex therapies that are available in medicine, and to really become a key access point and in your field because there is such a need that you can make a huge impact on patient care and patients' quality of life. And especially in pediatrics, like it is both challenging but incredibly rewarding to be able to integrate a full rheumatology is not one system. It is all systems because the immune system and inflammation can affect everywhere in the body. And so you are always having that kind of big picture view of the patient and the family and bring to bear all of your expertise on how to best tailor therapy and how to best manage this patient and this family unit as they are growing and as their disease kind of evolves over time. And so there's really I wouldn't be doing anything else. There is no better specialty to be in than rheumatology, and it just keeps getting better because our choices our tools keep getting better. Our knowledge of disease states keeps getting better, and so outcomes are just getting better and better over time. So it's a great time to be getting into the field.
Brandon, thank you so much for sharing your insights, your leadership, and dedication with us today. Your work really reminds us that improving access to care isn't just about systems, but it's really about the people, collaboration, showing up for these youth and families who often go unseen. So for our listeners today, we'll link any of the resources mentioned on the episode down below so you can learn more. And if this episode resonated with you, please share it with someone who needs to hear it. And as always, remember to like, comment, and subscribe. And I'll see everyone next time on Take a Pain Check. Thank you so much, Brandon.
Thank you, Natasha. It's been a pleasure.